Hi, this is Elliot Fishman, and welcome to, I guess it's part 7 of our most popular cases. These are the cases that you've liked the most on CTisus. Lily calculates the numbers, the magic, and then gives me the 10 cases, and let's talk about them. Okay, this is a great case. Look at the patient's skull. Look how it's thickened, and when you look at the patient's frontal bones, you look at the mandible, everything is widened, thickened, and has kind of a ground glass appearance. And that's very classic for fibrous dysplasia. Look at it, the coronal view. You can imagine the patient's lack of vision from that orbit, changes related to the frontal bone, changes related to the maxillary cavity. Here it is on the sagittal views. And again, really impressive involvement. And here's how it looks in the 3D imaging. A few brief points. Fibrous dysplasia of the skull. It's a benign chronic bone disorder where normal bone marrow and bone are replaced by fibrous connective tissue and weak trabecular bone. When it affects the skull and facial bones, it's craniofacial fibrous dysplasia. Remember, we can see fibrous dysplasia in other bones. We see it in ribs. We see it in the femur. It can occur as a single bone monostotic or multiple bones or part of a syndrome like McCune-Albright syndrome. The most common presentation is a gradual painless enlargement of the skull or facial bones, often leading to asymmetry, as you can see in this case. Depending on location, you can narrow the cranial foramen, and this, as you can imagine, vision loss, hearing loss, headaches. Growth typically slows down after skeletal maturity, though it can continue to expand in adulthood. And some of the classic CT features, ground glass opacity, like in this case. You can see sclerotic or homogeneous changes in bone. You can see cystic or lytic changes, makes you think of other bone lesions. And again, the expansion, which you saw in this case. And in this case, you saw both expansion and these ground glass opacities. Next case. Dilated esophagus. Yes, it could be esophageal cancer, but when you look at all the images, you can see it extends down to the GE junction, but there's no mass present. You can see lots of food in the esophagus. This is classic for achalasia. Achalasia is, something we talk about diagnosing on plain films. Big dilated esophagus. Could be the worst case of reflux you've ever seen, but very classic dilatation, not thickening of the esophageal wall, and changes at the GE junction. Again, esophageal dilatation, distal narrowing at the GE junction, increased wall thickness can occur, but it's atypical. And again, these air fluid levels we talk about very nicely shown in this example. Complications of achalasia, you can imagine with an esophagus that dilated, aspiration pneumonia. There's an increased incidence of malignancy, particularly squamous cell carcinoma, as patients get older. And you can get esophageal perforation, but it's rare. It's usually secondary to therapeutic intervention and not from the patient just having a perforation. Okay, case number 3. Look at the large uterus, marked enhancement. This is, when you look at the coronal views, look at the vascularity. This is a classic example, postpartum patient with this impressive vascularity and mass effect. That's gestational trophoblastic disease. It's fairly uncommon, but you can see the enlarged uterus and the large mass with impressive vascularity, very nicely shown particularly on the coronal images and on the sagittal images you can see here. Now, GTD, CT plays a critical role in staging, risk data stratification, as well as looking for metastatic disease. It has an elevated beta HCG level. What are the things we look at? We look at uterine enlargement. We look for a heterogeneous myometrial mass. We look for marked hypervascularity, as you very nicely saw in this case. Sometimes you can see markedly dilated vessels, which almost look like AV fistulae. As the tumor grows, myometrial invasion, thecal-lutein cysts are very commonly seen again, elevated beta HCG levels, and metastasis most commonly to the lung, but also to liver, GI tract, and the spleen. Differential diagnosis: uterine leiomyoma, more commonly leiomyosarcoma when the vessels are irregular. Again, you want to be careful in the immediate postpartum patient, particularly post-C-section. You can be confused with retained products of conception, but after a couple days, you're going to know what you're dealing with. And again, the beta HCG will make it very helpful. In this case, ground glass opacities bilaterally. It's increased toward the bases, but you can see on the coronal view it's diffusely involved. Yes, the first thing you think about is infection. We always think about infection, but with the density and distribution, you're not really thinking about edema. There are no pleural effusions. You got to be thinking about pulmonary hemorrhage. Now, I have to admit we don't always think about pulmonary hemorrhage. Classic findings: ground glass opacities. It represents filling of the alveoli with blood. We can see consolidation. The GGOs can progress to dense consolidation, which was happening in parts. In this case, air bronchograms are commonly seen. There's a number of findings that people describe, the so-called crazy paving pattern. We also talk about central lobular nodules. So there are many things you can see in pulmonary hemorrhage. One thing, it's diffuse and bilateral. Again, differential diagnosis, infection, other things like drug toxicities are things that could be considered as well. Because the CT features of pulmonary hemorrhage overlap with pulmonary edema or infection, clinical correlation is critical. Again, sometimes it's a matter of trying to treat the process till you realize what you're dealing with. In the ER setting, it's often not the first diagnosis you make, but again, with the clinical history, it can be made. But again, ideally, it's something you need to think about, at least keep in your differential diagnosis. Another case, large uterine tumor that's vascular. You can see a vascular uterus in the postpartum state, and that's what you may be seeing. You could see it as a large fibroid. You can see a leiomyosarcoma being very vascular. Leiomyomas in general are vascular, can be homogeneous, can be irregular. When they're really markedly hypervascular, you really have to be thinking about the possibility of sarcoma. And again, in the postpartum patient, very vascular uterus, you also would think about gestational trophoblastic disease. Just to review, typical uterine tumors that are hypervascular. Unusual are hemangiomas. I don't think I've seen one. And angiosarcomas, which are both very rare. Most commonly, leiomyomas. It can be a challenge sometimes differentiating leiomyoma and leiomyosarcoma. And then, as we spoke about, gestational trophoblastic disease is another possibility. In this case, there's a nodule in the right lower lung, smooth, well-defined. Now, I would look hard for calcification and for fat. I don't see it, but the lesion is really smooth. It would be negative on PET. You might biopsy it if you weren't sure, or maybe just take it out. depending on the patient's history. You want to look hard for a little bit of fat. There appears to be a little bit of fat present, and this was a pulmonary hamartoma. It's the most common benign lung tumor, accounting for about 75% of all benign lung nodules. Classically, mature cartilage, fat, fibrous tissue, respiratory epithelium. It's the classic appearance of smooth, well-defined, sometimes lobular, usually under 4 centimeters in size, and they grow very slowly. Key things: fat attenuation and calcification, or a combination of both fat and calcification, are things you want to look for. In this case, patchy infiltrates, air bronchograms, multiple nodules with cavitation. When I start seeing cavitation and infiltrates, I'm always thinking about septic emboli. Cavitary lesions, yes, you can get with metastatic disease, let's say a uterine leiomyosarcoma as one example perhaps, or other necrotic tumors. But septic emboli, usually peripheral, but they can also be central. But when I see multiple peripheral, often wedge-shaped nodules, I'm thinking about septic emboli. And this is a really nice example of septic emboli, as well as patchy infiltrates. Again, usually you can make the diagnosis, though sometimes it is relatively challenging. Septic pulmonary emboli, the characteristics classic when you have those cavitary peripheral nodules, but as in this case, it's not always a perfect example. Classic findings: multiple lung nodules typically, though it can be single. Size, usually under 3 centimeters, but from 5 millimeters on up. And margins typically are going to be indistinct. We also talk about a ground glass halo sign. The lesions will cavitate, and cavitation can be relatively quickly. You may see cavitation, you may see the nodules, you may not see pleural effusions, or occasionally you may see pleural effusions. One of the key differential diagnoses, particularly if a cavity is large, might be a lung abscess. So things you think about: septic emboli, differential granulomatosis with polyangiitis, cavitary metastasis we mentioned, particularly head and neck, and rheumatoid nodules are all things to consider. This is just a nice case. The patient was post-trauma, I believe, and you see twins. Again, we don't typically scan patients who are pregnant unless there's urgent reasons. One might be appendicitis, one might be looking for aortic dissection. And in the trauma patient, we always worry about the mom first. And this is just a nice example of a patient who's pregnant with twins. We don't see many cases of twins on CT, and this is just a very nice example. And people always like to see these cases, which is why it's probably so popular. Look at this case. Look at the spine. Every vertebral body and the sacrum are all involved. Diffuse sclerosis. This is not blastic metastasis. You also see the iliac bones and femurs are involved. This is a very classic appearance of renal osteodystrophy. It's due to chronic renal disease, the classic, because the kidneys cannot properly excrete phosphate or activate vitamin D. A cascade of secondary hyperparathyroidism occurs, leading to classic and very impressive radiologic changes. It makes the patients more prone to fractures and other complications. And again, it's a complicated process of bone resorption and osteosclerosis. That's why you have that really classic CT pattern. We talk about the rubber jersey spine. Again, while the parathyroid hormone resorbs bone, it paradoxically stimulates osteoblastic activity in the axial skeleton. And with renal osteodystrophy, the spine is really the place you make the diagnosis, But again, as in this case, the pelvis and other bones like the femurs may be involved. Last case, there's a nodule with feeding and draining vessels in the left lower lung, and that's a pulmonary AV malformation, very nicely shown on the MIP images. When I look for PAVMs, I love using the MIP imaging. It makes it easier to see feeding and draining vessels. You need to make the MIPs relatively thin, or you can overcall the presence of a PAVM. Now, PAVMs, pulmonary AV malformations, can be solitary or they can be multiple. They can be associated with certain diseases like HHT disease. We see a lot of those patients at Hopkins, and that's probably the main reason I'm looking for PAVMs. And again, the MIP imaging works very nicely. About 30 to 50% of patients with HHT will develop a PAVM, and they're commonly multiple, more common in the lower than the upper lung zones. Triad of complications, paradoxical embolization, hypoxemia, and hemorrhage. So PAVMs are typically treated before patients do get any of these complications. Again, from an imaging perspective, the feeding artery, the aneurysmal sac, and the draining vein are all things we look for to make the right diagnosis. So those are 10 terrific cases. They're part of the thousands and thousands of great cases we keep adding to CTisus. Go to the website, go to the teaching file, and you're going to learn a lot. And with that, have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.